go ahead and get started. I actually passed out a little note sheet to you because that's the major, when we get to that, talking about Crohn's and ulcerative colitis, those are the main ones where you might see such a similarity that you go like, hey, how can I do this? So this is actually something so that you'll be able to see what the commonalities are and then see what the differences are. So it's kind of like a little cheat sheet for you to create your own notes about what we're going to do when we get to that particular section. Before we get started, though, we're going to go back a little bit for yesterday, talk about some of the stuff we did yesterday as we go forward to today. Okay, so yesterday we talked about renal things, so we talked about chronic renal failure with patients, what kind of things we have to look for as far as management of patients, doing the assessment on patients. We also talked a little bit about BPH, prostate cancer, those types of things. Do you have any questions about stuff that we covered as far as the urinary tract side? Chronic pyelonephritis was also something we talked about yesterday. And most of those really, the nice part about the section that we're going into now, although y'all want to slap me senseless all the time, is that it really, when you think about A&P for these particular things that we're going through, it really is kind of leads you to what you need to look at for what's happening with the patient. What are you looking for as far as their diagnosis, how you're following up with the patient, how you're doing your assessments, medications, and treatment, and that kind of thing. So that, it makes it a little nicer for this particular section. The fluid and electrolytes part, with both of those you're going to see things that actually happen on both sides. As far as if a patient is hypo or hyper with an electrolyte, IV fluids, that kind of thing. And that was the assignment that you're turning in. And I'll make copies for everybody at the break so you can take those home. You already have part of your study guide ready for your exam for. Okay, but any questions on that stuff so far?
No, ma'am.
Okay. All right, so today we're going to talk about bowel diseases. The other part of yesterday, we did start talking about GI stuff. So we talked about upper GI kind of things. We talked about gastric and peptic ulcers, disease and medications, and we realized how many times we're giving medications when we really shouldn't. As far as treating your patients, but that is something that unfortunately when you talk about policies and facilities, that's kind of what you're kind of roped into. You're also seeing the challenge of when you're trying to tell people what's the right thing to do about giving meds so the patient has the best outcomes, you don't always get somebody that's receptive about doing it. So that will continue until you become RNs and then you can change policy. That's the thing. But even in your institutions, you still want to bring that back to people and say, we could be doing this better. Better outcomes for the patient is what we're all about. So I did tell you, send you an email to kind of look at this before we started, so you kind of get an idea of where we're going as far as looking at things in the intestines and the bowel. Okay. What are they really responsible for when you think about the overall function of the body? Absorption of nutrients, so that's what's going to be a big thing. So when you're thinking about forward, because you're always thinking about questions, right, for tests, that's what you always ask me, what's going on testing say? All right? So you're thinking about if it has something to do with the bowel where I have reabsorption of nutrients, where I have the formation of stool, all that kind of stuff going on. Think about if you have a person that has some dysfunction there, what kind of signs and symptoms you're going to see, or what indicates that this person has a problem in those areas. Okay? So first things we're going to talk about is inflammatory stuff. And that's, those little red things over there are my idea of inflamed. All right? So couldn't draw flames really well. So that's what you're thinking about, inflammatory process. Now what's interesting about these, diverticulitis I put first, because a lot of us in here already have diverticulitis. You're just not symptomatic. Okay? You have diverticula that are happening in your bowel. But that's something that we see as part of Western civilization, because we don't eat enough fiber, we're not doing the kind of things we should as far as vegetables and that kind of thing. So you get these little out pouches that happen within the bowel itself. And so that's the diverticula. When it gets inflamed, that's diverticulitis. Okay, so you know that itis on the end means what? Inflammation, infection. So you're thinking about what are those things that are happening to this patient because of that. So you have everybody has these, so a little out pouching. What generally happens in those is that you get either a seed or stool or strings, because celery is one of those things that can do it to you. It gets caught in the diverticula, it gets inflamed, and then you develop diverticulitis. Signs and symptoms of everything is abdominal pain. You're going to see those in all these things that we're talking about today. But one of the major symptoms that you see is lower quadrant abdominal pain. Patient also has nausea and vomiting. They may end up with an ileus, meaning that you don't have peristalsis going through because of the issue that's going on with the patient. Therefore, you have a person that has nausea and vomiting, abdominal distension, those types of things going on. Now, because it's an itis, what is going to be part of my treatment? Antibiotics. You always know that there's going to be a piece whenever you have anything in the bowel. You're always going to have an antibiotic that goes with that, and you never give just one. Because remember what's inside there? Bacteria, nasty stuff, right? Gram-positive, gram-negative, so you have to give coverage on both sides. So you usually get some type of penicillin drug, unless the person is allergic. And then you're also going to get the antifungal flagyl. It's usually going to be a part of what you do for any inflammatory thing that's going on with the bowel. If I really want to lower the amount of bacteria that's in the bowel, I mean before the patient goes to surgery or something like that, you also give neomycin. It's an antibiotic, but it has great properties as far as lowering the amount of bacteria in the bowel. So that means if I'm going to cut this person open, I want to have the least amount of stool, least bacteria in the GI tract. So when you see a patient get neomycin, sometimes it's not on a continual basis. You'll see that the day before surgery. So they're going to get cleaned out first. And then the other part of that is that you're going to give neomycin as part of their prep. But diverticulitis is common. Remember how we talked about things that you're going to see on NCLEX tests are always going to be things that are more common as far as your disease process. They're not going to be crazy things that happen to your patients, but those common things. So in your assessment of the patient, you're thinking about, what am I going to see? Okay, yeah, they complain of pain. Well, what other things might you think you'll see on their abdominal assessment? What might they be doing? Besides crying. You know, I'll be crying. I'll be guarding. Okay, they might have tenderness. When you palpate, all of those things would be signs and symptoms you see with your patient. Now we know this is something that's happening in the lower GI tract, so how do you think we're going to do the diagnosis?
Colonoscopy.
Colonoscopy can be part of it because one of the things they can do is actually do that. Now that's going to be invasive. Short term, we can just do an x-ray because you can actually see the diverticular pouching out. You may also see the patient get barium. Because that's one of the things. What do you always want to make sure when you have a patient who has barium does after the fact? They need to drink a lot of fluids because you need to make sure you actually see it pass. Because barium can get hard in the bowel, and you don't want that happening to your patient. So that one of the things that you'll see is, yes, I'm going to give the patient barium to swallow. I can see it. It actually fills in the area, so you can actually see the outpouching that they have there. Those types of things going on with your patient. But the fact is you have to make sure that their stools are chalky looking because that means they're passing the barium. You know, those kind of things going on. But I will tell you that sometimes they'll save that kind of thing until after you have some decrease in the inflammation. Mainly because if something ruptures, you don't want barium going into the bowel itself. So x-rays can reveal a lot of that's going on. Plus the doctor's looking at the index of suspicion. What is this person complaining about? Where is their pain located? They're doing those types of things. Looking at their CBC results. Because part of infection is my white count is going to go up. So leukocytosis that you see associated with it. So you're looking at the broad spectrum of things that are going on with the patient. So how do you think we're going to treat them? What aren't they going to be able to do? They can't eat. All right. So you're going to have them NPO. They usually do have an NG tube initially because sometimes if they have an ileus or the abdomen is distended, I'm going to have to pull those fluids out of there. So they have an NG tube to low suction. So you're taking out those things that the person has. They're going to get their IV antibiotics. Pain medication, we do have to address that issue with pain in patients, but we don't give them a lot until we figure out what's wrong. If you give patients a lot of narcotics, when we're talking about assessment of abdominal pain, you can't really tell if they're having a problem because it covers it, it masks the pain. So you don't give them a whole lot. We do give them some, but we have to make sure we make the diagnosis first because it can be dangerous on the other side. Now the thing about it is you're going to continue to watch and look at the output that the patient has from their NG tube. You know that is always an opportunity for a math question, which y'all hate. Right? But part of what we do when you're talking about, especially if a patient has a lot of secretions coming out of the abdomen, you have to replace that fluid. So sometimes you will see orders on the chart that says give the patient cc for output, meaning that if they had 600 cc's out in their NG2, you're going to replace that on the next shift. So you increase their IV fluid so that it gives them that normal rate that the physician orders plus that 600 over the 12 hours or 8 hours that you have. Sometimes they'll do a half a cc. It's always up to the doctor to figure out that particular part. But just know that sometimes you have to do that. And that's mainly because you got a lot of fluid in your abdomen. That's like a third spacing issue. Not stuff that your body can use, but your body notices that it's not there. So you're trying to replace that to make sure you have good urine output, blood pressure stays stable, pulse rate stays stable. So you don't see those things that are going on with a shocking type patient. But once they, you're gradually going to see how their output is getting less, hopefully from the NG2, bowel sounds are returning, less tenderness, less pain, white count is going down, then that's when I'm going to take the tube out. You don't take it out too early, because if you take it out early, the patient ends up having problems. You got to put it back in. You also don't let them drink a lot of water. Patients always want ice chips continuously, right? Give it to them all the time. But if you give a person NG2, if they have NG2 dissection, and give them a lot of water, it's also causing problems with their electrolytes. So that's not, even though it sucks it out, you still have issues with them having that problem. So you don't really want to do that for the patient. But once it comes out, you may have a person who's still NPO, but then they're going to progress their diet. So ice chips first, clear liquids, full liquids, soft diet. You never put a person right back on food. The bowel has to re-energize itself, okay, because remember, it's been quiet, it's not working, it's just chilling. That's what essentially happens. So now you have to get it to wake up and start moving again. Wait for peristalsis to come, listen for those bowel sounds, and that would be the fantastic thing for it to happen for the patient. So that's that's the goal when we're talking about getting this patient back to where they need to be. Then it's going to be patient education, because every piece or every disease process that you have, you get questions about patient education. So what are some of the things you're going to teach this patient about this disease or disorder? Their diet. A big thing for them is going to be diet. So they need to understand that yes, when you're once you're healed up, because remember, when they're inflamed, you're not doing this. But when they're not inflamed and they're getting back to their normal bowel pattern, that kind of thing, what you want to do is increase fiber in the diet, increase activity. They stay away from things with seeds or strings. You're like, what is strings? Celery is the main culprit when you're talking about that. But a lot of stuff has seeds. Carlos brought me some nice things with seeds in it. I love them now.
A whole bucket.
A whole bucket full. But I don't have diverticulitis. I'm pretty sure I have a diverticulum, but I haven't had diverticulitis. But you want to get rid of anything with seeds, because those are things that get caught in the diverticulum, cause the problem. Nuts, those are, people don't think about it, but that can end up being a problem. That's when you can get rid of those chia seeds. They're supposed to be really good for you. They gross me out to watch people eat them.
Is it small, like sunflower seeds? No.
Yes, it's really not supposed to be any type of seed that's small.
Any size.
Yeah, because you would do better. I mean, if you just really have to have nuts, because some people just don't have to have everything. You just have to be careful about how you do them. Either you crush them up really fine so you don't have a problem, because that's usually what, you can make things almost a paste and you still have the taste of the nut, as opposed to eating them and they get caught and you have a problem. But the major thing you want to do is make sure they understand about you need to do some dietary changes, because that does help prevent recurrence, because it's something that once it starts happening in the patient, it can happen over and over again. And you try not to do surgery on the patient unless you have to, because surgical intervention is not the first thing that you want to do. But if you have patients who are refractory to treatment, they're not getting better, those may be things that you actually have to end up doing for your patient. But that's an inflammatory thing that just affects the bowel. And that's why I put that one first, because the other two are not just something that happens with the bowel. They actually have a multi-system issue that happens with them when you talk about patients who have Crohn's or ulcerative colitis. Because we're going to see a little video that kind of goes along with that. Kind of reinforces that. I think I told y'all before, my mother has ulcerative colitis. And she was diagnosed when she was 70, which is bizarre, because you usually see it before, the diagnosis before that. But part of it was what her doctor said, because when I was sitting there listening to him, he goes, I said, she's 70 years old, man, are you crazy? That's what I'm thinking. What is wrong with you? And he says, well, she's been treated for arthritis all these years, because she's had arthritis since she was in her 30s. And that it just kept it under control enough. And then she had a stressor, which was the death of my father. That was the thing that put her over. And then she was having symptoms, bloody diarrhea, all that kind of stuff. So that's why, but she has all the other things that go along with that, because part of what you see with patients who have these disorders, which they think are autoimmune, and part environmental when you talk about ulcerative colitis and Crohn's, is that it affects the skin, it affects your joints, it affects your eyes. So those are the three major areas where you have patients who have issues not only when you're talking about the bowel, but also in other areas in the body. And we're going to see that as well. So you have a little sheet there that kind of puts them so you can see, because these are going to look a lot alike. Remember I told you when things look alike, you got to figure out what makes them different. So in that big box, you're going to put your commonalities, those things that are similar as far as if you look at a Crohn's patient or you look at ulcerative colitis patients. Okay? So because those are some things that you're going to see there. Then on either side, you have a little box that says differences. So what makes it different? Because you know you got to look at, part of that is saying that, oh, these are the things that make it a little bit different, or sometimes it's very pronounced what it makes it different. So that way you'll be able to kind of go, hey, which one of these things is going on? What you will also see is that the treatments are pretty much the same anymore. Because if you're looking at commercials on TV sometimes, you see the things that we're using for these, they say Crohn's disease / ulcerative colitis. Or you'll see that the foundations and referrals that you give to patients say Crohn's and ulcerative colitis foundations. So they actually look at them together as far as being able to provide information to patients, management issues, those types of things. Okay, so that's the nice part about that, is that once you have a patient who has a clearinghouse about information, they can get it from one source, but their disease process is a little different. Management is a little different in some regards. Outcomes can be very different, mainly because this is one of those disease processes that you can have people that have relatively mild disease all the way up to patients with very severe disease. Okay. So these are the two that you're going to kind of see a lot of things that are similar as far as when you're talking about your patients. When you talk about Crohn's disease, we'll do that one first. It's an inflammatory bowel disease, considered subacute, but one of those things that you see in this patient is going to have periods of exacerbation, meaning they're going to have periods when they're worse, periods of remission. Okay, so, and then one of the things that's characteristic that kind of fits in that box at the top that says they're the same is that diarrhea is part of the process. Abdominal pain is part of the process, because you're going to see that on both sides with patients. So abdominal pain, diarrhea are things you're going to see with both sets of patients. Crohn's disease tends to happen when people are teenagers in their early 20s, and then you see another spike when people get 60 years old. But it can happen at any age. Okay, so it goes across the spectrum, but you tend to see it in relatively young people. The older I get, the younger it gets, kind of thing. All right, so you tend to see it. It can happen in teenage years, all the way up to when a person is elderly. But you're going to see that spike kind of thing between the teenagers and early 20s, and then again at 60. So those are people that when you have a person coming in, you always think, well, if you had this disease, you should have had it for years. Like I was thinking about my mom, ulcerative colitis. Yeah, you could have, but some people don't express the disease until something happens. And that's part of the reason why they say there's a genetic predisposition, there's an autoimmune influence here, and the other thing is environmental. So what are you being exposed to that might be causing you a problem for the patient? Okay. Now another difference that's with Crohn's disease is that it can happen anywhere from the mouth to the anus. Okay, so even though you're going like, how is that possible? And yes, I have up here that it's a problem with the bowel and the intestines. That is true. But also, if a patient has Crohn's disease, can have it anywhere along the GI tract. That's the difference, because ulcerative colitis does not do that. Okay, so you have one major area that's affected when you're talking about a patient who has ulcerative colitis. That's just the colon. Okay. But when you're talking about diverticulitis, it can happen anywhere along the GI tract. So that makes a difference. That's one of those big differences that you see. The other thing about a patient who has Crohn's disease is that it affects all layers in the GI tract. That's the difference. Ulcerative colitis only affects the innermost mucosa within the colon. Because remember, abdominal pain, diarrhea are the things you're going to see that make it similar, but you have to look at what is different, because management is going to be the same. Okay, so that Crohn's disease patient, we know it's an inflammatory response. You already know what is part of the treatment. Because what does that flame got to do? You got to put it out. What is one of the things we use to put out the flame? What drug class?
Steroids.
Steroids. Because that's part of the treatment that you're going to see for patients when they have acute exacerbations. You never like to use steroids for a long period of time, but what you want to do is get that inflammatory response under control. So it's a drug class that you would use to actually manage that. Okay. Now that is because this is inflammatory too, so guess what? We're going to use them on the other side. So steroids go into commonality. Because that's what we're going to do. It's an inflammatory response. So medications that I use for the patient are going to be a lot alike on both sides. So that's the similarity kind of thing. All right. Now because this can happen anywhere, and you start to see destruction of the mucosa, you start to see a muscle layer develop in the bowel other than what's supposed to be there. When you look at them under endoscopy, these patients actually have a cobblestone appearance to their bowel, meaning that you're going to have periods or parts of your bowel that are normal and parts that actually that have disease. So that's why they talk about cobblestone. And if you think about old-fashioned cities like Savannah, you know, I love going to Savannah, and how you're going down the street and you're kind of going along because it's a brick road kind of thing. Think about that's essentially what's happening in the bowel, is that you're going to have areas where everything is perfect, and then other areas where you have disease.
That's your Crohn's?
That's your Crohn's. So that's the patient. That's something that makes it look different again, because that's not the same thing that happens with the ulcerative colitis patient. So disease can be all over, remember, from the mouth to the anus. Can also be, you have a whole section of bowel that has no problem. Then you have sections where it just kind of jumps around. So they call that cobblestone appearance. And what they're finding is what's even better as far as diagnosing patients who have Crohn's disease is actually using that little capsule that you swallow. That takes time to go down your GI tract and take pictures all the way down. Even though you can do endoscopy, one of the things you have to worry about is those cobblestone areas, when they're inflamed, you can puncture them easier. So it's better to actually have the patient swallow the pill, take the pictures all the way down. Have you ever seen that? The first time I saw that, I was like, what? But it's kind of neat. You know, you're seeing that it's taking pictures as it goes all the way down. Patient passes it, take it back to the hospital, they do all the pictures, and they can see every part of your bowel as it's doing it. So I don't know. It looks kind of big when you see it. I've never seen one in person. I saw it on TV, and I'm thinking, how do you get that down? Hurricane spray and anesthesia knocked me out if I had to do that. All right, so then you just want to make sure, but that's going to give you a good picture of what's going on. You can do endoscopy as well, but they found by research that you get better pictures by doing the pill. So that actually takes pictures as it goes all the way down the patient's GI tract. Now the other thing about the commonalities here, remember I told you there's things that you see that happen with your patients. They have syndromes that are associated with them. Because it's autoimmune in nature, they think it's something that's attacking the body on its own, because that means your body's doing stuff it shouldn't be doing to itself, but it does. Okay, so the first part of it is the bowel stuff that you see in the patient. The other commonalities that are between both of them is that you see people that usually have dry eye syndrome. You know I can't say the name, so don't even ask me. I can't say it. I can't even spell it either. Something like this. I think there's another O.
Sojourns.